51-year-old man with a medical history of hypertension and dyslipidemia. As a cardiological history, he had an STEMI in 2021 due to thrombotic occlusion of the middle circumflex artery that was treated with a DES implant. The patient consulted due to typical chest pain of 10 hours of evolution but was referred to our hospital 3 days later. In the lab results, we observed an elevation of troponin and the EKG showed a ST decrease in precordial leads. 48 hours ago, an angiography was performed. A stent thrombosis of the circumflex artery and a moderate lesion in the median LAD were observed. In the first cut, thrombus aspiration and implantation of a new stent was performed. In addition, the kissing balloon technique is performed at the bifurcation with the obtuse marginal. However, the result is not optimal, with timid flow. At the moment, it is decided to stop the procedure, and today we will perform an OCT on the artery and see if the result can be optimized.
I can show you the setup. That is a radial approach 6 French, an EBU guiding catheter, and Santiago performed some angios before. I'm going to show you right now. You can see the stent of the flow is much better than the other day, but you can see some haziness at the distal part of the stent. I show you another projection here in the distal side. That is an enormous vessel. And this is the lesion at the mid part of the LAD that we are considering to include in the vulnerable trial. So Santiago did an OCT, and as you can see, with after crossing the OCT catheter, the thrombus moved forward and reduced the flow in one branch of the obtuse marginal. And after dilatation here, the flow was recovered. And the OCT was analyzed. So Santiago is going to show you the results of the OCT.
Yeah, thank you, Alfonso. This is this representative case of one of the problems of performing a second procedure with thrombus, with residual thrombus. And the question is, how many times do you need to wait to avoid this embolization of thrombus? The OCT show, as you can see here, this is the distal part of the stent. There's red thrombus firmly attached to the distal part of the stent. And in this middle part of the stent, you can see how there are 2 layers of stent. There is the previous stent that was completely occluded due to a very late stent thrombosis. And this is the amount of thrombus that is between the 2 layers of the stent. You can see that the stent that we implanted 2 days ago is good expanded. In the very proximal part there is mild malapposition. It's only 1 quadrant, and there are still remnants of thrombus in the proximal border. We have commented the case and we have decided not to touch because the risk of new embolization, and we think that we should wait maybe 1 month or even 2 months to evaluate again this stent. If the amount of thrombus is resolved and there is a bigger malapposition, then we should post-dilate this stent.
So we are retrieving the first wire from the circ, and we are advancing the comet wire through the LAD.
So you have seen the lesion of the LAD. The first step is to evaluate functionally with FFR. Of course, if the FFR is positive, the patient needs to be treated. There is no place for the study. But if the lesion is not functionally significant, then we study with OCT to evaluate vulnerability of the lesion.
Well, the comet wire is a pressure wire distributed here by Boston Scientific. It has the possibility of performing a non-hyperemic index, the DFR, and also the FFR using adenosine or regadenosine or whatever. And it's quite some advantages are that it is quite easy to plug in and out the wire to the connector, and also the wire is quite good to use as a conventional workhorse wire because It is probably one of the best characteristics that is performed as the Asahi wires. No, so it's a very good wire to use for a functional measurement. Okay. When it is stable, we can equalize. Now. So we're going to advance the wire.
The OCT system is Abbott. What is your algorithm between selecting OCT and EBUS? So in this study, we are trying to select the vulnerable plaque. So they are using just OCT, no EBUS.
In this study, the third parameters that we analyze to evaluate the vulnerability is the amount of lipid plaque, the thickness of the fibrous cap. That is a measurement that is only visible with OCT, and the third is the plaque burden.
Okay, and we will see. We are starting with the FFR measurement with intracoronary adenosine.
Para empujarlo.
We are administering how many micrograms?
One more question.
60 por cc, voy a ponerle 3 para empezar. Que
180, okay. Okay. Tosa un poquito.
Tose un poquito. Tose un poquito. Ya está, vale. Vale.
Okay. Okay.
Yeah.
The adenosine have been effective.
So FFR 0.91, we can review it, Danny, to see if there is another point with lower FFR, but what I see is that the FFR is negative.
Yeah, it's clearly negative.
It's clearly negative, no?
Yeah, clearly.
Okay.
And yeah.
I have retrieved to be sure that there are
no drift in the wire. Okay. We can disconnect this, no? To be more comfortable.
Yeah, you can disconnect to perform the OCT.
I don't know if you are seeing my hands with the camera.
Yeah.
Yeah, and look, this is quite easy. You push the button, and this is disconnected, and it's the same to connect again. So we're using this wire to perform the OCT and eventually the PCI if it is needed. So this is a crucial part of the study. We are doing the OCT, and then the analysis of these results are crucial to include or not the patient in the study, because it needs to have some criteria of vulnerability in the plaque. Danny.
Another question. How distal do you place the catheter for FFR?
Yes, it's a good question. I think just distal to the lesion is enough. Probably in this case we have gone much more distally, but it's negative even there. So we are sure that the result is negative.
If you think that there is some distal disease, or this is a focal lesion, so we could be go more distal, but I think is not necessary in this case. We only want to analyze the focal lesion of the mid-LAD.
Me si hace falta más cable, me dices.
Entiende un poquito. Contraste, Ali.
Well,
you can see how the OCT has induced a slow flow. Let's see the characteristics of the plaque.
It's quite a tactic vessel, no? It's similar than the CERC. No sé qué estamos
Cabe un
haciendo aquí,
poquito
pero
de
estamos liando.
nitro, Ali, porfa.
The flow is improving.
Vale, un toquecito. Test. Vamos a hacer un cine.
Okay, the flow is recovered now.
Okay, let's check the OCT. This is the distal LAD that is healthy vessel with the 3 layers. There is some fibrous plaque in this point. You can see the structure of uniform and highly brilliant, highly refractive
image. No?
And you can see here the image is changing. Now we can see a lipid pool in this part of the vessel. You can see that in this point the vessel wall is visible, but due to the high attenuation of the lipid tissue, we cannot see where is the vessel wall. And in some point we need to measure the thickness of the fibrous plaque.
So the first criteria, I think, is fulfilled or something?
It's lipid, yeah, it's a lipid plaque. In this case,
more than 270.
In this case, nearly 3 quadrants.
Okay.
And in some point, the fibrous tissue is nearly in contact with the lumen, so probably it's a thin cap fibroateroma. So to measure the plaque burden, it's a limitation with OCT in the point of maximal stenosis, because the lipid tissue does not allow. There is another point of fibrous tissue, and you can see a line of highly reflective tissue that this zone probably correspond to macrophages in the plaque. So we need to estimate the plaque burden in the relation between the minimal lumen area and at this point of the maximal stenosis and a reference point in the distal border of the plaque. And you can see.
So we have randomized it, and the election is PCI.
PCI.
Mm-hmm. Yeah. So.
Okay, so we can use this pullback to measure the dimensions of the stent. Probably we don't need to predilate a lot.
No, as direct stenting could be the best option.
And also with this slow flow phenomenon, probably the best thing is not to touch a lot, just to implant a direct stent if we can. We are
reviewing with OCT the stent size that we must choose. You can see the proximal part is near 5. The distal part, the diameter according to the elastic, the external elastic lamina is 3.7, and the length of the lesion is about 19.
Okay, can we have please a stent 3.5 by 20 something?
You can see in the proximal part there is still lipid plaque, so we need to go more proximal to this point, about 20.
Now, seeing at the same time the OCT and also the angio, probably we have enough space to land and be comfortable of landing in a healthy zone. Probably Santi is right, and 24 or something like that could be nice. So we are implanting a 3.5 by 24. Choose what is la marca? An Elunir stent, 2.5 by 24.
Another one is if we have any experience with evolocumab in these patients.
No, probably this kind of pharmacological treatments can induce a positive remodeling of the plaque, increasing the thickness of the fibrous plaque and decreasing the amount of lipid tissue. But it's only a hypothesis. And this study, the vulnerable trial, is also a hypothesis, a different strategy to trying to stabilize vulnerable plaques.
Mm-hmm.
We need to wait to the results to if we can, what of the two approaches is better if there is one.
Mm-hmm.
Se ha ido un poquito para arriba.
Ahí,
vale,
¿no?
ahí estamos. Respira suave ahora, Raúl.
4.
Dale a 14.
6. 8. 10. 12. 14. Good expansion here. We'll see another projection, very good expansion and going down.
Vale.
Una jeringa, por favor. So we can review it with OCT again, or?
Yep. I'm thinking about the deterioration of flow. What can be?
Yeah.
I don't know.
Happens?
Probably these are ectatic vessels with the same.
I have this suspicion of there would be thrombus inside the lesion, but in the OCT there is no thrombus.
Yeah, probably it's a good point of vulnerable plaque.
Sí,
Yeah.
sí, sí. ¿Tienes guía? ¿Suelto?
Sí.
So the audience were asking about the FAME 3.
Please, another pullback of OCT.
But then the main thing is that the thing that Santi said, that FFR is only to discard the clear functional repercussion in these lesions, and then only those without positive FFR are studied by OCT. So these are different settings.
Contraste. Yep, I was reviewing this distal part, the healthy vessel. This is the distal landing of the stent. You can see there is no dissection. The distal size was good. There is no significant protrusion of tissue between the struts. The expansion looks good. And in the proximal part, there is a small malapposition that is only a few millimeters, 2-3 millimeters, near the proximal border. If it's possible to post-dilate to obtain a better position.
I think so, no? With a 4-0 balloon, probably?
Yeah, at least.
I think so, no?
Sí. Un 4.8, por favor, de un no completamente 4.8. I think
Yes?
sí. We have learned with complete and other trials that multivessel revascularization after MI is improving outcomes, but studies that have been guided with FFR, like the Flower MI, have failed to demonstrate some advantage over guiding, angiography guiding. So I think that most of the benefit that we can observe treating this lesion is not related with severity, but is related with the stabilization of the plaque when you implant a stent.
Okay.
12?
Down. Un poco más distal, ahí vale.
Yo creo que vale, era solo el bordecito, sí.
We have post-dilated the proximal edge of the stent. Test, please.
¿Quieres hacer otra OCT o terminamos? Yo creo que
terminamos, ¿no?
Sí, porque no vamos a posdilatar más.
No, we are not doing more.
Que vamos a ver
another projection.
Un pequeño
This
test,
one probably.
cómo está el vaso, ¿vale?
Okay. Cuando quieras. Okay, very good result, I think. We have also the OCT confirmation. So very interesting case to recap everything. This stent thrombosis previously in the circ. With this haziness, we have reviewed with OCT, and we decided not to touch now. Probably we are going to review in a couple of months, or leaving the drugs, the antiplatelet treatment to do this their job. And this vulnerable plaque, non-culprit vulnerable plaque in the LAD that has been randomized to the trial, to the arm of treatment, and we have implanted a linear stent guided by OCT with post-dilatation, and this good result.